Okay, so very good evening to everyone present here. Let me share a bit about Empower. Empower is a group that was made, with the aim that we'll hold educational sessions, monthly educational sessions, and these will be slightly different. They are actually, designed keeping T1Ds in mind. So things which are not discussed in big conferences, something which is, more from our learning perspective, and something which is not necessarily always medical. Yes, we do discuss medical aspects, but also very practical tips for people living with type 1 diabetes. So here we are together to advocate for good clinical practice, as well as collaborate on research work, posters in national as well as international conferences. We are a team of passionate clinicians, advocates, educators, and coaches. Now I hand over and invite Dr. Amit Kumar Dey. He's the chair of and founder of Empower T1D. And because of him and the team, we are all here today together. Okay, Dr. Amit Kumar, over to you.
Thank you very much, Riddhi. A warm welcome to everyone. So just to give you a highlight about how we started, there was always a thought that there is a need of collaboration between the two people sitting on the opposite side of the table, the patient and the doctor. Type 1 diabetes is one disease that we've thought that this gap needs to be addressed by bringing both the individuals on the same side of the table. And that's how the thought process of Empower T1D community came into existence. And I was asked by many people that why another community when there are so many excellent foundations and organizations are there. So Empower community is actually going to try to fulfill that gap that kind of bridges between a clinician and a T1D patient or a T1D advocate, bring everybody on a single platform with an intent of collaboratively sharing the knowledge and exchange of ideas. Because all of us are actually fighting for the same goal, but sometimes there is always a need gap that comes in, and that is the small gap that we are trying to fulfill. So, our predominant aim is going to be through educational sessions, mostly online educational sessions. And the content that we will be bringing will actually be a mixed content in true sense where the physicians, the clinicians will also be picking up some nuances by learning from experts, senior experts like we have today. At the same time, our individuals with diabetes will also be getting in some hands-on tips of how to go about with their disease. So it all started about some months back, 3, 4 of us. I can see Dr. Manisha is over here, Dr. Rutul Goklani is over here, Mahek, the 4 of us, we got together and we floated in this idea. It has already started with a community or WhatsApp group, and now we are very happy. We've got about, I think, more than 30 or 40 plus members in the community, and we are always growing. And we constantly feel that this is a community that will be actually led and supported, not just by clinicians or physicians, but also by T1D advocates and T1D individuals who are working towards T1D education equally. And with this thought, hence comes the birth of Empower. And we've been doing some activities, we are doing some research work. And today we are really happy to have two very senior experts with us, Dr. Archana Sarda ma'am, Dr. Rishi Shukla sir, and they've been the mentors to most of us. And I'm sure they will be continuing to guide us, the Empower team, with their mentorship and with their guidance going ahead. So with this small introduction, I welcome you all. I can also see that there are a lot of physicians also who have joined us here, many T1 individuals. So today's session is going to be a very practical approach to type 1 diabetes, both with the physician's perspective as well as the perspective of an individual. And this is what, a combined technology-based session can bring us, and it can all bring us together. And we're really happy to share with all of you joining in today. We had an overwhelming registration of 118 participants, but we will be probably be able to allow only 100 people to join in because of the limitation of the Zoom capacity. So all the very best to everyone. And with this, I now hand over back to Riddhi to carry forward with the session.
First of all, my sincere thanks to Dr. Archana and Dr. Rishi sir for joining us today. We really value your support as well as the learning and experiences that you can bring to this community. With that, I'd love to introduce Dr. Archana. Uh, Everyone has heard of UDAN, and if you haven't, it's my pleasure, as well as I take pride in introducing UDAN as an NGO founded by Dr. Archana. Today, she supports more than 1,300 children with type 1 diabetes from the town of Aurangabad as well as rural Marathwada region. And not only with, basically not only with free cost medical care or, support with psychosocial support, education. And, she also guides people for their career as well as how to find partners within the community. So she's a consultant diabetologist, but also a mother and grandmother to so many children living with type 1. Also, I take the pleasure in saying that she was awarded the RSSDI Woman Physician of the Year 2022. And there are so many other achievements to her credit, but we'll just keep it short and crisp. She's leading the RSSDI National T1D Task Force as well. Over to you, Archana ma'am. We are really looking forward to some insightful tips from you on how to manage type 1. And today we are going to focus on the adolescents as well as the young adult population. There are things which we don't really commonly hear on other platforms. So we look forward to a wonderful and engaging session. Thank you.
Thank you, dear. Thank you, Riddhi. Thank you, Dr. Amit, and thank you, T1 Empower Group. Honestly, you cannot imagine how happy one feels, First, you see yourself as a mother and grandmother. Today, it's like a dream come true. I mean, I used to see Dr. Rishi's work. I got inspired. I did my own work. But now to see younger people and more younger people coming together on their own, carrying this torch forward, and now we feel okay, I can retire in peace and sleep one day. There's so many good people out there. Love you all. God bless you. Please carry on this work any way we can ever be there. I mean, in any capacity. I'm sure I speak for Dr. Rishi as well, that we will be more than happy, and it is absolutely heartwarming to see the efforts that you have taken. I will now share my slides. Just give me 1 second. Are the slides visible?
Yes, they're visible.
I'll just make
visible, Archana, yes.
Hanji, visible? Yeah.
Yes, go ahead.
Right. So I'm going to be talking about type 1 diabetes care in adolescents and young adults. Now, as you can see in this picture, these are all young people here, but they came to me as children. So when last 20 years, when we have seen their journey of growing up and seeing the pains and aches, and we also had all the pains and aches along with them, because I have to confess, I am an adult physician, and training myself in pediatric diabetes, feeling inadequate, not being an endocrinologist, but there was no choice, because the area where I come from, there was not a single setup which was actually treating children or young people or adults living with type 1 diabetes. So from that scenario and that journey, I feel that it's important that we talk about some aspects which are not always talked about. So no financial disclosures here. Photographs are being used, but they're all being used with permission of the young people who will be featuring in the photographs. And all the references, academic references that I have used are from the ISPAD guidelines 2022, which I would recommend everyone to read, because it's very elaborate and very specific, I think very well written. One disclaimer that probably when the topic was given, there was some expectation maybe of glycemic management. But when we're talking about the adolescent and young adults, glycemic management plus everything else, which means the pubertal changes, the communication, mental health, sexual health, and what happens when you become an adult, all leads ultimately into complete type 1 diabetes care in a young adult. So I am today not going to talk about the glycemic management. I will be only talking about the big yellow circle there, because that is something I feel is not addressed often, not by just people. Obviously, people living with type 1 diabetes themselves go through it, but it is not being addressed structurally. It was not being addressed by us at Udan till we came upon it. And we felt the need, and sometimes it was too late. And we have learned, and that is something I feel now that every guideline says so, and so should every clinician, every NGO, every support group look into these matters. With that thought, we are going to talk about the adolescent and the young adults. Now, the reason we are talking about this as a group is because this is the transitional phase of development between childhood and emerging adulthood. So this is that in-between phase, and definitely it has been established that the healthcare and emotional needs are distinctly different from younger children and mature adults. Now, of course, this may sound like a mother's opinion, and all the young ones in this group who are watching might get angry, but still take it with a pinch of salt and fun. And that is how we see the anatomy of a teenager's brain. So there is so much space for birds and bees. There's a rebellion center, super rebellion center, music center. Everything else is there, except maybe a place for diabetes self-care. So I have just included that little red spot there, trying to find, and this is about all the adolescents who I see, trying to find there must be some place in their brain which has a small little dot which represents diabetes self-care. And that is how we see this when we get frustrated when things are not happening. But see what happens. See from what answers we get. Look at this child telling his parents, how am I supposed to think about consequences before they happen? Now, this is how we all talk to our young ones, whether it is clinicians, whether it's educators, whether it's parents. Ultimately, it happens that if you don't take care, there will be consequences. But that is something that's not registering out there. So this whole language, which is different, the whole priorities, which is different, the whole purpose of life, which is different. And if we are not going to come to the same page, we may not achieve the targets that we are talking about. So if we call them difficulties, then the difficulties in the interactions with adolescents and their behavior is not just in our homes or in our clinics, it is every single place. So the biggest registry that was done, the T1D exchange in the United States, it showed a marked deterioration because it was followed up for the longest time, and the glycemic control at the ages of 10 and 20 years was there was a deterioration. Now, these findings are not isolated, as you can see here, are not isolated to only United States, but they are found across the globe. And there's so many papers, so many studies, so many things that people are sharing when it comes to this, right? Now, but it may not be universal. There are centers which have been able to crack it, and that is what we need to learn. Okay. Let me see if I can move the slide. Yeah. So today I'm going to very briefly talk about the endocrinology of puberty. Just go through it because I understand now. Earlier I thought it might be more clinician, but since it's community, type 1 community, just going to go through it a little bit. We're going to talk about identity and communication because that's one major factor. Mental health, sexual health, and about becoming an adult. So as far as endocrinology of puberty is concerned, why are we talking about it? Even if you're a person living with type 1 diabetes, or you are a support group and an NGO, if you're a diabetes educator, if you're a physician like me, and of course, if you're a pediatric endocrinologist, then you definitely know, if you're an endocrinologist, you are trained to think in that way. But other than that, is at any given time, this part being looked at? And is there a lot of blame that comes because we don't understand the physiology that's happening? So it's important to understand that there is insulin resistance, which is even without diabetes, which has implications for glycemic control as well as risk for complications. Now, growth hormone levels are higher in type 1 diabetes at all pubertal stage. And therefore, there is that observation is validated of the increase in insulin resistance in type 1 diabetes. Do we have experts for the evaluation? So this is a question for all of you, that in our own clinics, in our own setups, if we may not be capable of doing it. Very often I would send a growing child to a pediatric endocrinologist because I feel inadequate in handling that particular age group. But all of you, whether you're advising a friend or an NGO, I would just want to say that we have to keep in mind that we need experts for evaluation from an endocrinology point of view. Now, why do we want to keep that in mind? Also, because there's so many things which present and we don't realize there could be a medical reason also. So it is now well established at this age in adolescent and young adults, there is physiological insulin resistance, the effect of gonadal steroids, and there's a rise in the lean body mass leading to increased insulin requirements. As a result, glycemic control does worsen. And that is very important. We know there are modifiable factors of psychosocial and behavioral changes. We're going to talk about them. Adherence becomes less, treatment regimens become haywire, physical activity becomes less. Yes, those are aspects we know, but there are also medical aspects, physiological aspects, which is important to understand so that we don't always blame. We look for solutions. Of course, there are so many ways we can treat, which your treating doctor will be guiding you. But right now, my interest is to sensitize in understanding the other side of it. Even at this age, there is an increased risk of decay because the growth hormone affects the insulin signaling pathway at the post-receptor level, leading to the state of insulin resistance. Now, this leads to an exaggerated ketogenesis in adolescents with type 1 diabetes. So it can predispose them to glycemic decompensation and decay. So this is something that they are prone to. Yet, there are, of course, other factors, but often we focus on those other factors, like there is more decay episodes in this age because of underlying mental health problems. We're going to talk about that in detail, and it could be including self-harm and personality function. So normally after a decay, we would give re-education regarding sick day leaves, but it's also important that we talk about mental health assessment prior to discharge if a young adult has come in decay. Of course, we're not talking about at detection, but at later stages. Also, we know that it can have an adverse impact on growth and pubertal development. And we know that insulin and leptin are essential for growth. I'm not going to go into detail, but there can be hypogonadism. Then growth, of course, nowadays with the advent of modern insulin, it's only with uncontrolled diabetes with HbA1c levels, it correlates. Otherwise, it is almost normal. But one can see menstrual irregularities, ovarian hyperandrogenism. So it's important to get an evaluation in that pubertal spurt with an expert. And that is important. And that will only happen if as an educator, you're talking to them, or as a parents, we make them aware that this is an important aspect. Another point here is the additive risk for development of diabetic complications. So these risks are independent of effect of glycemic control. Now, this is also very important to understand that there is data which suggests that the risk of vascular complications, such as proliferative retinopathy and nephropathy, with the pubertal versus postpubertal onset of diabetes is more. The risk is attributed to insulin resistance of puberty, again, the changes in the growth hormone IGF-1, androgen, and again, greater adiposity seen during adolescence. Last but not least, again, a very important aspect in puberty, which is a physical change, and hence it needs to be talked about, is the increased fat mass. Body composition changes with increasing weight, and especially during puberty, and with girls in particular, showing increased fat mass, and it may be as a side effect of intensified insulin regimen and as a subsequent state of relative leptin resistance. This can make them in turn more prone for PCOS phenotype and ultimately increase their cardiovascular risk. We all know that body habitus change also leads to negative impact on body image and also can lead to eating disorders, insulin omission, all that we're going to talk about. But there is a physiological change happening. This is not something in their own hands. And that is why these few processes which come as part of physiological endocrinology of puberty should be known to the person living with diabetes, their caregivers, educators, even NGOs who are counseling, so that they can refer, they can address it, not themselves, but with the specialist at the right time. And even clinicians, if I'm not capable of, then I should be able to refer them to the right place. Okay, so once we have the body as such, we're talking about the physiology, the endocrinology, but there is so much that we are often unable to touch. So I am going to take you through a pathway where these are the components of young people that must be addressed, maybe as a checklist, maybe as a detailed workup, but these are factors which cannot be ignored because they have a direct impact on compliance, on outcomes, on HbA1cs and complications, and of course, quality of life. So identity and communication. As you can see, this boy, he's saying when I was 5, I was told I should be a big boy. At 10, they said, why don't you become mature? So he says, by the time I become an adult, I'll be like in social security and an old man. So young people don't know what. When they're kids, they're asked to behave like elder people. When they're elder, they're told, why are you being so serious? Be like a kid. So it's all very confusing. They are at an identity crisis. How old are we? How are we supposed to behave? Are we mature? Are we dependent? We don't know. Do all of us have a link to peer group support? And I'm very happy that we are on a platform which is about peer group support, which has started with peer group support. But if we talk to all clinicians across the country, do they have been roaming around the country doing various projects? And I was in some part of the country where they didn't even know that it exists. They had no clue what it meant to have a peer group support and no clue on how to organize something, where to link people. So it's very important that we have this question in our mind if we are working in the type 1 space. So communicating with the diabetes community is not a topic I need to take here, but it has shown that it has proven, there's lots of studies which show that it has a crucial role in day-to-day management and improve self-management and physiological outcomes, especially in young population as they go older, because otherwise they were in healthcare provider and family. Now, as they grow older, it is time to move on to peer support. And that is what they are seeking. So there are 3 main sites of communication. One is the diabetes online community, which many of you are so wonderful at, and this is one of them. Then structured settings like peer support groups or peer mentoring programs, and everyday conversations and interactions with families, friends, or peers, where this becomes normalized, where living with diabetes becomes normalized. So that's a very important factor, part of treatment, and has to be seen that way. Similarly, school and college communication and identity. We all know the challenges. We don't have school nurses. So many do have, but in India, you know what the situation is. Again, the knowledge that the teacher has, the access to the diabetes tool, is there freedom to perform whatever self-care is needed, nutritional availability, the communication between parents and the school personnel. Interventions are many. There are many good papers being written about it, many efforts all the way from the training programs to school letters to different interactive activities that are happening from the school nurse to the government to the school health program. But what I want to emphasize here is when we are counseling a child in our clinic, whichever spectrum they belong to, school or college interaction has to be addressed. And that is often seen much later. I mean, when everything else about diabetes care has been done, that is when it is seen. But if this is done early, then it has shown that peer support in school improves quality of life as well as is associated with better glycemic control. So a child who doesn't want to take insulin in school or doesn't want to eat a specific tiffin in school or do carb counting in school, if this is addressed earlier, then all the teaching you had about the insulin and carb counting and dosing would work so much better, because that is the kind of mindset. Sadly, there is also communication which can go wrong in the family. Sometimes things are not beyond our control, as in single parent, large number of children, reduced economy, and parent literacy. All these things is what I see in Udan. And we see so many negative family environments. We see mothers who have abandoned kids, fathers who have abandoned families, constant lack of communication or negative communication from parents. Now, as a clinician, as a supporter, as a organization who wants to help them, it becomes very difficult, because if the family environment is like that, what are you going to do? But it's very important to address it. So when we are talking to young people, it's important to have a comfortable environment where they can share this, where you can find out directly, indirectly, through various ways, so that some intervention can be thought of. But it is all over the world, not very effective interventions were found. I mean, even the family teamwork, communication, family therapy, all that has not so far been really given great results. So nobody has a clear solution. It may work in one family, but we have to keep on trying. Very interestingly, interaction with the healthcare services also often inadequate. There are so many young people who says our doctor or the educator doesn't understand what we want. Because if they are aspiring for some priority, and if our care is not centric around what they are aspiring for, then they just stop hearing. They feel that you don't understand what I want. If I want to run a marathon and you are not letting me, giving me a solution of how, rather than telling me why not, for example, is that just takes away that connect. So it's very important that we learn to communicate, and this is usually done with a technique called motivational interviewing. So everyone working in this space, if they learn that, get trained in that, and if that is incorporated, it has shown very good results. So we were talking about the physiology. We talked about the communication needed. Now I would like to talk about a topic which is rarely talked about, and that is sexual health. So I really like this cartoon where the teacher is saying that I would like to begin today's essay with the phrase, this year, the thing I have been thinking about most is, and you can see that every student is thinking sex, 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 but they can't say it. They're just thinking it because nobody's talking about it. I work in a rural space, and all these young adolescents, they come and open up with all kinds of thoughts, and they say that, ma'am, don't tell anyone, because there's no one they can tell, neither their mother, nor their sibling, nor their teacher. So are we a safe space for the youngsters? That is a very important question we should ask ourselves, whether we are an institute or a clinic or NGO or whatever we are, wherever we are we a safe space? That's very important. So I'll just, I want to emphasize that sexual health counseling is extremely important. Consider religion, consider culture, consider the familial perspectives before we advise, and a non-judgmental approach to sexual activity or sexual orientation. I'm going to leave you with the thought that one girl comes to me and she's 16 years old, and she tells me that she is into a physical relationship with her boyfriend, and tells me not to tell her parents. What should I do? What would you do? How would you counsel her? What will happen? So these are very, there's no, there's no right answers. What if one of your group came and told you that, okay, I am homosexual? What would you do? Would not tell the parents? How would you counsel? So these are things which are important, and can they open up to you? Is it possible for them to tell you these things? And how do we guide them towards a healthy sexuality? What is healthy, appropriate for age? And in cultural context, can we be non-judgmental, not preachy? It's not easy, but there is no other way. So this is something we must learn, we must understand. And of course, when we're talking about sexual activity, ultimately it will lead to preconception counseling. And this is very early. I'll go back to this. The age is not 18, 19, marriage. This is like 13, 14, 15. That is the time, just pubertal age. That is the time we start the sexual health counseling, because the youngsters today are sexually active. And I work in rural areas, and I know so many of the youngsters are sexually active, and they have a different way of looking at it. So what's our job is to guide them towards a healthy sexuality. Again, the concept of preconception counseling has to be told, especially when they have irregular menses, they think they can't get pregnant. So all that has to be told, that even with high sugars, with menstrual irregularities, you can conceive, and that's not okay for the baby. And family planning, contraception if they're married, and contraception even if they're not. So a very important topic is contraception. I realized that rarely is a sit-down talk about contraception happening. I mean, I was doing a contraception talk with my girls only when they got engaged. That now they're good. And then also they used to say, okay, you just got engaged, not married. I said, yes, okay, but let's talk about contraception. But then now I realize it should be done way, way before that. And contraception, young people with diabetes without micro and macrovascular complication may use any hormonal method. That is important that we learn about which contraceptions. Again, people with complications should avoid using OCs, but can use IUDs or barrier methods. Newer OC pills are safer because of the low estrogen dose, and they don't really have a direct effect on glycemia or weight. But still, there are some studies which associate them with poorer cardiovascular profile. So if a young person with diabetes is on OC, they should be monitored regularly, and that is something we have to talk to them. That's very important. A very controversial point is the last line. Sexually active young people should also be advised about the availability of the morning after hormone pill. I got a call one day, frantically, not day, night. I got a call at around 12:30 midnight and saying, ma'am, I was at a friend's place and one thing led to the other and we ended up having sex. Is there a pill I can take? Is there something I can do? I'm in a panic. In addition, saying, don't tell my mother. Now, this is a question mark. What does one do? So I'm going to leave it open-ended and we can discuss it at the end. But at least there is a morning after hormone pill, which they should or we should know about. How frequent? See, if we don't tell them about it, they'll find another way. So I don't believe in not informing. Of course, at the same time, we can inform them on how to make right choices or judicious choices. That is important. Once we have moved on from sexual health, we will quickly talk about mental health. Now, it's a huge subject by itself. I mean, mental health and diabetes can be 100 talks together. It's a whole chapter. But we often do not address it because we are inadequate. I would say that I am inadequate. So this is just a joke that, a girlfriend broke. That's a gingerbread man saying, because she dumped me for a guy with fewer carbs. But a thing like that can be a trigger for a mental health issue. So my question to all of us is, are we trained for mental health screening? And if we are not, if the answer is no, then let's get trained, because there is no way we can do type 1 diabetes care without addressing mental health. Diabetes distress is one aspect. Anxiety and depression are the two. So diabetes distress is a negative emotion, which is basically arising out of the self-care for diabetes. It is quite common in 30%. Sometimes it can lead to overdiagnosis of depression. So it's very important to assess it properly with the right manner. And it is usually diabetes distress which causes chronic hyperglycemia rather than depression. So it's very important we diagnose it right. Depression and regular screening for depression is absolutely important and will help us to identify people who need intervention. Let's not confuse it with anxiety and distress. Hence, again, proper evaluation and screening. The treatment is CBT. Wherever CBT is not available or is inadequate, there medications might also be needed, which have given good results. I would like to tell you that we did screening for diabetes, distress, and depression in Udan, and we were very surprised with our results. But what we got as a result has mobilized us totally into looking at mental health of all our young people, and we are progressing on a path which I would share, but we have included it as part of our protocol as much as we see a BP, as much as we see a blood sugar similarly. Okay, is this moving? Yes, no. Sorry. Yes, anxiety. These are disorders which are characterized by intense anxiety. Why is this important again? I mean, there's so much about it. We can't summarize it in 2 lines. But what I'm trying to say that anxiety and depression can be masked by irritated and stubborn young people. So what projects as a non-compliant, stubborn, angry, rebellious, irritable young person is actually a person who is extremely anxious or depressed or living in diabetes distress. So this mask that the young people carry, and unless we analyze it and address it, we are going to miss out on a lot of things. Another very important aspect is drug and alcohol use. We have to talk about it. Let us not look at the holier than thou attitude. All young people talk about drugs, especially weed. Every school, every college, every nook and corner today, weed is available. I believe it is on the verge of marijuana. And I hear weed all the time, is that it's like on the verge of being approved maybe for, from the government. That is what I'm hearing. But all three, and they may be using it to manage distress or just for entertainment. And even after we counsel them, they're going to follow. That may not be true, but it's very important we talk about it. Something will click, something will stay, something will become judicious, and that's what we hope. Last of these mental issues that we were talking about are the eating disorders and body image. What is very important here is the degree of overeating and insulin omission is what a clinician needs to assess, because that will determine the clinical risk of acute and chronic complications. There are screening tools, and this should be handled by an expert, because it's important to use the right tools to find out what is actually happening. And there will be specialist service for diabetes management in such a case, as well as food problems. So I have quite a few girls now, I think 3, mostly they're girls, maybe because of the body image issues. I have 3 girls in Nuran now who do have these issues, and they're being addressed jointly by us and the psychologist. This last point is the recurrent diabetic ketoacidosis. Very simple line. Any person who lands in DK again and again, take it as an indicator to suggest that either that individual, their parent, or the caregiver is struggling with mental health or a frank psychiatric disorder. Because once you've ruled out the medical problems, it is extremely likely that it is self-harm. And I personally know of girls who threaten their parents by omitting their insulins and land up in problems. And this is a serious psychiatric mental health issue. Let us not leave it. Last stage of the journey, and I will just take 5 minutes, I'm conscious of the time here, is about becoming a young adult. So we, from puberty to mental health, sexual health, and finally, we are now an young adult. So becoming a young adult is not just a stress for people who are becoming adults and moving on. It's also the parents. Look at this cartoon. He's saying that you can come down now. The children have grown up and left, and the parents can heave a sigh of relief. No. Actually, no, because a bond is never broken. Everyone is always connected. Nobody is truly ever independent. It is interdependent, but roles may change. So I want to ask all of you that because they're young adults now, is the young person at the center of our management plan? Is everything we plan centered around their life? And if not, then it's time it happens that way, whether it is their insulin regime, whether it's how they'll monitor, how will they access their food, everything from their medical management to everything else. Because they're going to be doing studies and examination, that is a time, it has to be tailor-made. We know all these issues, but telling them also that hypoglycemia and hyperglycemia can lead to cognitive effects, they should know that. Again, accommodation should be conducive. All the facilities should be available. And again, we have to do their insulin regimes to maintain euglycemia during the exam. Absolutely. There will be people who are up all night. There will be people who are up all day. So we have to decide which one we are going to go for, what to do. This is a puzzle driving, which I have never been able to solve so far. Maybe all of you can help me because we don't have a law. So we understand all the other aspects. Hypoglycemia is a main risk factor, and we can easily guide, counsel, train, teach, use CGM, everything. And that way can do very safe non-commercial vehicles. But what do you do with young people who are driving commercial vehicles also? I have 2 young boys who are driving commercial vehicles, and they are not well controlled. And there is no law. I've been trying to talk to everyone because nobody asks who the driver is. If a person who's driving your car today, or a taxi today, or a bus today, does he have diabetes? Does he have hypoglycemia? India has no laws. So I'm at a total loss what to do here. But our job is to counsel them and take this as a very serious piece of advice in part of the treatment. Employment, yes, we always tell them to tell their employers, create a discussion from the very beginning, because a young boy will come in, I want to go to the army. So we should know what jobs are not okay. Okay as in not allowed, what jobs are difficult and what are good. So it's good to guide them that way, but teach them that be responsible self-care in the workplace. Sometimes people don't discriminate. We only do not go out of the way to do it. So it's very important that at time we do that. And last step is leaving home. So whatever care was happening, it was a two-way transfer. Now, over time, it will become a linear transfer of all the behavioral management. The young adult has now to do his academics, travel, having a home, money, and ultimately marriage, and have his own family. So this entire process is gradual transfer has to happen over time, and yet the bond is not truly broken. It shouldn't be that now you're out and okay, bye-bye. It is always a bond that can be taken care of. One more group we need to talk about, and that is the socially vulnerable adolescents, because their priorities are totally different. This is Usha, who lives in the Lonar. She lives in a 5x5 jhopdi hut. How will her priority be a normal HbA1c? She goes to the field every day. She has a family of 7. Everyone needs to feed each other. So very consciously, when we talk to a person, it's very important, at least once a year, do the social determinants of health, whether it is money, it is education, it is distance, availability. Also, there are 6 to 8 social determinants of health. And whatever are the social unmet needs, either we source them or we plan in their absence to give appropriate care. So that is something also we have to keep in mind when we are looking at young people with diabetes. So with this, I will end saying that let's make ourselves very inclusive and comprehensive. Medically, scientifically correct, yes, that has to be so. But at the same time, be very inclusive, very non-judgmental, and absolutely comprehensive, that so no young person is left behind, no matter what their background, what their inclination, what their sexual preference, what their state of mental health. Everyone has to come along and have a good life. Thank you so much.
Wow, thank you. Thank you so much, Archana ma'am. I think this was such a relevant and a very comprehensive way of discussing type 1 diabetes care. It's very, very inclusive. We went through all the unmet social needs, the taboo topics. Even we in urban areas, sometimes we don't have people who we can open up to and share. And all the more we need it for all our rural support kids as well. The importance of peer support group is someone from a city also, like when I remember my journey, it wasn't easy to reach out to peer support groups because we didn't even know at that point they existed. Touching upon sexual health counseling, these topics are never discussed, and I'm so glad that you've given us a very unconventional approach. So thoroughly enjoyed, and of course we'll take up questions in the panel discussion. So with that, we move on to our next speaker, Dr. Rishi Shukla sir. I'll introduce Dr. Rishi Shukla sir. He's been the head of the Department of Endocrinology at Regency Hospital, Kanpur, and the chief consultant at Center for Diabetes and Endocrine Diseases at Kanpur. He has over 50 plus national and international publications. He's been an integral part of changing diabetes in children, CDIC in India, member of RSSEI Task Force for Type 1 Diabetes, and a recipient of many awards, like the IMA Kanpur Ratna Award, Lifetime Achievement Award by the ACP chapter, and so on. Thank you, Rishi sir, for sparing your valuable time. And over to you for the session.
Good evening, friends. And first I'll share and then I'll speak because sometimes I get stuck. So let first problem be sorted out first. My slides are visible?
Yes, sir.
Okay, I'll make it full. Uh, Is it moving also? Is it moving or not?
No, sir.
Not moving.
Sir,
Okay.
can you keep it on slideshow?
I have put on slideshow.
Uh,
I'll do it once again. Screen share. Just a minute, I think. Is it moving?
No,
sir, the
No,
speaker has
okay,
stopped.
okay. Mm.
Sir, if I can suggest, kindly share the full screen rather than sharing the PowerPoint. Sometimes it works.
Okay.
Yeah. If you can share the whole screen and then open the PowerPoint, it'll probably work.
Okay.
Yeah.
Mm. Am I audible to each one of you?
Yes, sir, you are.
Yeah, all right. Mhm.
Sir, in the share option, there should be something called share entire screen. So if you could share the entire screen, that will come
I've
up.
done. I've shared the entire screen. Now,
Yeah. Now just keep it like this. Now just open the PowerPoint from the tab below. Yeah, we can see your screen, sir. So all you need to do is now just open the PowerPoint. Yeah.
Yes.
Yeah. And
Now
go for
we-
full screen.
Yes.
it is done.
Yeah,
Thank
Perfect.
you so much. Thank you so much. Thank you for help. First of all, Amit. And thank you, Riddhi. And thank you, Empowering Diabetes Type 1 programs. I'm feeling so happy and peaceful that the things are moving forward because if I go back correctly, almost 30 years from 94 to 2000. Archana, when did you start?
20 years back.
So it is 30 years, 10 years. I'm almost 10 years ahead of you,
Hmm.
maybe a little more. When I started, I used to ask people to have one talk in RSSDI or Endocrine Society, and they put. I remember first time I think I spoke on Endocrine Society of India, Udaipur, 2000 or something. They asked me to speak. Then I put one more talk, and then a couple of talks in RSSD, and then I kept on asking. Then they said, "Come and speak." Then I said, instead of saying asking me if other peoples are also involved. And now I'm very happy to share that in almost all national meetings, RSSDI, Diabetes India, many state chapters, Endocrine Society of India, there are at least 1, 2, 3 symposium of type 1 diabetes. So we have moved the way forward. And I think 2007, I did first meeting inviting people. I share every time repeatedly, but this purpose is that not I did, but it happened, number one, and it generated interest for all like-minded people across the country. And now I'm seeing the fruits in form of Amit Dey, Riddhi, and many known faces. Suchi was seeing, Mehak was seeing. So all good people are there. Harkabir is not visible, I think, but anyhow, thank you so much to make my heart beat positively, to make my heart beat with a bit of endorphins and so many good things. So with this, I think I'll start with my talk. Archana spoke very well. Actually, after your talk, I was thinking I need not speak. It would be good if I share what all you thought and sharing my experiences. And I got inspired and I wrote in a paper that because I was avoiding sexual counseling somehow. Mental health was being covered. We off and on we have been asking a clinical psychologist also to seek the help, but sexual counseling was not being done very regularly. So I learned from you. Thank you so much to help me even at this stage of my life. So I'll be discussing the associated endocrine part. This would be more of a medical part, but there would be a little bit of cross between me and Dr. Archana. So what I'm going to discuss a bit of thyroid disorders, celiac disease, Addison disease, polycystic ovarian disease, erectile dysfunction again in young adults and adults is not being discussed, then hypogonadism. So my slides are moving. All right. First about thyroid. Since this is a mixed population, so I'll touch. So at the end, those who want to share, they can talk. Because type 1 and thyroid both are autoimmune disorders, so share a common connection. And it is in 70 to 30% of type 1 diabetes, so very huge. And risk of hypothyroidism in type 1 is almost one-fourth of patients. And what is interesting is that poor diabetes control predisposes to autoimmune thyroid disease. So good control probably saves from hypothyroidism and maybe some other autoimmune disease. This is actually interesting slide that look at the autoantibodies. They are present in 25% of patients as against the normal population, which is present 10%. So almost 1.5 times, and 5 to 50% in difference it is converted into autoimmune thyroiditis. The larger part of these patients will develop hypothyroidism, but a subset of them will develop hyperthyroidism because we have both types of antibodies. So this is very interesting, and I would request that usual recommendations are every 5 years, every type 1 should get their thyroid test. But I think nowadays so many tests are there, so at least once a year they should get their thyroid tested done. And duration of diabetes may be a risk factor for type 1 but not type 2. So this is again an interesting finding here. The behavior of hypothyroid is different in type 1 and type 2 diabetes. And the risk factors are hereditary, increasing age, puberty. The female gender are more prone for almost all autoimmune disorders. Estrogen use, pregnancy makes them more prone, and association of other endocrine disorders. Polyglandular failures, including type 1 diabetes. The management of hyperthyroidism, this is actually interesting. The standard management, I'll not be going into detail like antithyroid drugs or radiothyroidine or surgery. These are the 3 modalities we use. But the interesting thing is if the patient is having subclinical thyrotoxicosis and their TSH is between 0.1 to 0.4, then treatment should be considered with history of coronary artery disease, stroke, or atrial fibrillation. So these are the things we start seeing in patients who are having diabetes for more than 15, 20, 30 years. Because I have a number of patients who have diabetes for almost 50 years. Sorry, hypothyroidism treatment is simple. Thyroxine treatment to everyone, and if the TSH is more, they should be treated. One important thing is the thyroid treatment improves lipid profile and reduces insulin resistance. So lipid profile should be considered when patients are euthyroid. There is no role of thyroid scan if the patient is having hypothyroidism. I'm not talking of ultrasound, I'm talking of nuclear thyroid scan. And in case of ketoacidosis, Dr. Archana talked, thyroid function should be considered even with little suspicion, because thyrotoxicosis is one entity that makes them prone for ketoacidosis. And second thing is a small clue to all of you. If your blood sugars are heavy, moving here and there, sometimes thyrotoxicosis comes in a very subtle manner. The symptoms are very less. So the thyroid functions serve a very important, because once it is diagnosed, it is easy to treat. And the use of statin should be considered after making patient euthyroid. The celiac disease is again a common thing that we see. 2 to 25% of patients. So not at all uncommon. It has a significant impact on growth, bone density, and glycemic. So all three things: growth, bone density, and glycemic control. And I would also say the pubertal development, because growth comprises all this. Non-specific features frequently result in delay, because many times it is so subtle that symptoms are hardly there, or very small GI symptoms. This was a paper, I think we had some work. My colleague, Dr. Anurag, did a major work. I was part of it. And celiac disease in Indian children, adolescent with type 1 diabetes. And what we did, it was a retrospective analysis of 208 type 1 diabetes. TTG IgA levels were done within 6 months of diagnosis and annually on follow-up. 14 subjects were negative in beginning, and they were diagnosed during follow-up. So this is important. Once negative does not mean negative forever. You keep on doing it, maybe once in a year or once in a 5 years. And our study, the prevalence of celiac was 25%, which I shared with you because the range is 2 to 25%. Addison's disease, we seldom talk, but I found it interesting. I need to share with this. The patients with type 1 diabetes and patients with Addison's disease need lifelong replacement therapy with insulin and glucocorticoids, respectively. And the concurrence of two things, type 1 diabetes and Addison's disease, comprise a treatment challenge due to counterbalancing effects of insulin and glucocorticoids on glucose metabolism. This is actually last under this line is very interesting. Patients with diabetes, the HbA1c is a very excellent diagnostic and therapeutic biomarker for the control, but we don't have such marker for Addison's disease. So there are a lot of other things that we consider, like electrolyte imbalance or growth or our clinical understanding. What are the issues? The incidence of Addison's disease in patients with type 1 was 193 per million. But if you look at the downward slide, the risk of developing Addison's disease among patients with type 1 diabetes is 10.8 times higher than the general population. So they are much prone to have Addison's disease. So this is very interesting area. Patients with concurrent type 1 DM and Addison's disease had 4.3 times increased risk of death than patients with type 1 DM alone. So it is good to detect. And up to 60% of patients with autoimmune Addison's disease have an additional autoimmune condition. So if the two things are there, we need to search for a couple of other conditions also. Then insulin versus cortisol. Having both type 1 DM and Addison's disease is complicated. The management of both diagnosis during an infection or other stressful condition is challenging in order to prevent adrenal crisis and manage hypoglycemia, or because if there is an infection, you have to increase the dose of steroids, and when you increase the dose of steroid, the sugar automatically goes up. The chances of getting ketoacidosis increases. So one has to be very careful. And this is the situation where you can use infusion pumps also. Because of these counterbalancing effects on glucose metabolism, patients with type 1 DM present with reduced insulin requirement when they develop severe glucose deficiency due to Addison disease. And what are the early indicators in patients with type 1 diabetes? Infections requiring hospital admission, multiple complications of diabetes. And this is very interesting. Diabetic retinopathy. It is 12% versus 2%, Addisons and non-Addisons. The prescription of thyroid and other, if there is any other associated endocrine disorders, one should probably look at Addison's disease. So diagnosis, I'll not be going into detail, but any cortisol level more than 500 and no more excludes cortisol deficiency. And there are stimulation tests. We have long synectin. The synectin is now available in India, so you can use 1 hour synectin test, IV synectin test. And the time of Addison diagnosis in patients with or without type 1 diabetes, the chances of Addison disease I shared with you is many-fold compared to general population. Polycystic ovarian disease, Dr. Archana just mentioned it, but there's an interesting association of type 1 diabetes and polycystic ovarian disease. Is the most common endocrine disorder in women with reproductive age group, irrespective of type 1, showing a 6 to 15% prevalence. Insulin-resistant compensatory endogenous hyperinsulinemia in close association with obesity and abdominal obesity are implicated in pathogenesis of PCOS. Women with type 1 diabetes needed supraphysiological doses of subcutaneous insulin, and exogenous hyperinsulinism could then contribute to endo. So type 1 diabetes, they have become overweight, their insulin requirement has increased, and there is endogenous hyperinsulinemia as well exogenous hyperinsulinemia, and both of them contribute in development of polycystic ovarian disease. And type 1 diabetes in PCOS, the prevalence of PCOS in type 1 diabetes is up to 24%, which is very, very high. In studies, especially reporting the prevalence according to different definitions of syndrome, the prevalence of androgen excess related traits in women with type 1 diabetes, hyperandrogenemia, was present in 25%. The prevalence of androgen excess traits, particularly hirsutism, were also very high. So all the features of PCOS per se is quite a common entity with type 1 diabetes. And the word we use, double diabetes, probably double diabetes is invite to polycystic ovarian disease. Difference in women between type 1 diabetes depending on presence or absence of PCOS. Exogenous systemic hyperinsulinism may be involved in the pathogenesis of PCOS and women with type 1 diabetes. Actually, the environmental factor and the dietary factor are also equally important. The glycemic control and daily insulin doses were similar in patients with type 1 diabetes presenting with or without PCOS. Higher mean A1C levels since diagnosis of type 1 in patients presenting with PCOS, and women with under intensive insulin treatment had a significantly higher prevalence. So more strictly you control, the doses are more, the chances of PCOS increases. So there is a complex link between type 1 diabetes and polycystic ovarian disease. But one thing for sure, that this is one of the common disorders, and this is one thing where we can do something, because like other diseases, thyroid, hypothyroidism, Addison's, or celiac disease, we simply need to diagnose here by care, because many of my type 1 diabetic patients have become double diabetes. They have gained weight. And then they have PCOS on one side, and the young males have erectile dysfunction on the other sides. So endogenous hyperinsulinemia because of obesity, exogenous hyperinsulinemia because of excessive doses, and the two contributes together. PCOS and related hyperandrogenic traits appear to be among the most common comorbidities in type 1 diabetes. PCOS may contribute to subfertility of these movement by mechanism that does not directly depend on glycemic metabolic control, among other negative consequences of their health. And screening of PCOS and androgen excess should be included in current guidelines. I think this is very interesting. We should look at while we are asking good number of tests, why not test for screening PCOS? Erectile dysfunction, my younger colleague touched. I think Dr. Manisha is sitting, she has some work on erectile dysfunction. I would say now, Dr. Manisha, I've been thinking now I'm sharing, we can do some work in this area if we have some time to spare. Because you are very busy. Because aging and diabetes are the most common risk factor for erectile dysfunction. And besides aging, diabetes is the most common risk factor for erectile dysfunction. 35 to 90% of men affected by diabetes. Actually, there is a psychological association of diabetes and erectile dysfunction also. 4 men are sitting together, 2 are having erectile dysfunction. यार तू ठीक है तो बाकी सबको तो हो जाता, तुझे अभी तक हुआ क्यों नहीं है? And then they start developing erectile dysfunction. No, there is some problem with me. And epidemiological studies suggest that both type 1 and type 2 diabetes are associated with increased risk of ED as compared to general population. 3 times high risk of ED in diabetes versus normal population. And erectile dysfunction occurs 10 to 15 years earlier than normal population. ED is more severe and less responsive to treatment. What is in type 1 diabetes? This was a study, I think I'll be going into detail. And the overall prevalence in type 1 diabetes was around 37% among diabetic men and 6% among controls. So almost 6 times higher erectile dysfunction in type 1. So this is eye-opening, I think, for all young adults. And Dr. Archana has very nicely discussed. So I think above 18, above 25, we should ask them if there is any problem in erection. The odds ratio for ED in type 1 population, type 2 population was 8.5%, 8 times higher. And the prevalence of ED was similar in both, whatever mode you are using, but it is seen. 37% is a big number. And ED prevalence of both of these groups were higher as compared to controls. So to conclude, the prevalence of erectile dysfunction was consistently higher in whole population of diabetic men as compared to aged. I mean, if you look at type 2, it is much more because multiple things are there. ED prevalence rates were not different in diabetic men treated either with MDI or CS. This is again very important. The overall prevalence 37%, as I shared with you. Prevalence rate of ED as well as IF score were similar in diabetic men treated with MDI and CSI. So in ancillary study, DCCT and prevalence of ED was significantly lower in intensity, but later on it was found that whatever mode you are using, the erectile dysfunction is there. Obesity, poor glycemic control, smoking, and psychological disorders. I think what is important of all these 4 disorders, they are all reversible. We can control obesity, we can go for good control, stop smoking, psychological disorder. I think alcohol is also, we want to add, we can add alcohol also hampers sexual performance. In presence of a study, in present study, men with ED showed lower weight body mass index as compared to men without ED. So this was again an interesting thing. It is also associated with other endocrine disorders, type 1 diabetes, polyendocrine disorders, and which is rare, but as I shared with you while discussing Addison's disease, because when 2 endocrine disorders are connected together, diabetes plus one more, we should rule out and look for other endocrine disorders. So I think with this, we are stopping. Archana, you can identify yourself. Dr. Deepak Dalal, Sunil Gupta, Madhukar Mittal is, and I think it was Jodhpur, moved to somewhere. Dr. Ish Bhatia is actually a star. He was a HOD of endocrinology, SGPGI. I have worked for some time at SGPGI, and he was the one person with whom I'm inspired to do something about type 1. So my all good work is dedicated to Dr. Ish Bhatia. At the moment, Dr. Ish Bhatia is working in Apollo Medics, Lucknow. So my gratitude to Dr. Ish Bhatia, and because of him, I could do some good work. Thank you very much, and thank you, each one of you, for kind attention. Thank you so much.
Thank you, Rishi sir, for an enlightening talk. I'm glad we could touch upon all the different endocrine aspects of T1DM and also get a little bit of good solid foundation from the scientific and medical aspect also. And it's really nice to know what are the autoimmune conditions that are linked with type 1 diabetes. So thank you so much. Dr. Rutul, if you're available, we could have your views on today's panel, and then we'll open up for questions. Dr. Manisha, how about you? If you're,
Dr. Manisha is here, yes. Thank you,
Yes,
Manisha,
I'm very
for
well here, sir.
taking care of me. She was after me that everything moves on time.
No, sir, and the talk was, as usual, it was nice, and I learned a lot from you and ma'am again, and it was a like revision of the entire topic. And regarding the ED issue and the study, we did a study with when it was during the COVID time. So during how the COVID impacted the sexual dysfunction in male. So that was the time when we did, and it's published as well. And we are as busy clinician often do not get enough time to do the justice to our patient. But I really like wish to do something. And regarding ma'am's presentation, ma'am, like whenever we ask and open about the sexuality, especially in the women, uh, they become, especially the teenager, all the adolescent, though we know that they're sexually active, still they do not open up. So how do you address this issue? Like as I start they say, मैडम हम हमारा ऐसा बैकग्राउंड नहीं है, आप हमें गलत समझ रही हैं, हमारा ऐसा फैमिली नहीं है. And later on, once I don't know how to address this and how to tell them.
I think it's a very double-edged sword. And you being young, like I have raised my own kids to become older and gone through these phases. So we learn, from real life situations. And the key is to be absolutely non-judgmental. If there have been lots of conversations already where you have shown that you are open to young people being sexually active, and that is the only time they will come up to us and talk to them. So I often, we, at least in Udan, what we do is we have different age groups. Right now we have girls groups on different days. So currently, if you have both the genders together, there is not enough space for this kind of conversation. So we have girls days and we have boys days and we have age segregation and with no parents. So that kind of environment, if I tell a story, for example, I always, now I'm being very upfront about it. I always tell them a story, how my first boyfriend was when I was in 8th grade and I had a crush on him. I mean, half of them are cooked up, I'm telling them now, but they are just to get them to relate that, okay, and I know what I used to do. I used to write him love letters because we didn't have a phone. So all kinds of things, gradually they realize that, okay, I can relate. So we talk about some things, we talk about such stories, and gradually they have to have that faith that we are on the same page. Otherwise, they will not. That's why they don't tell their mother, they don't tell their sister, they don't tell their friends, because they're going to be judged.
Yeah.
Everyone wears that garb of culturally right. Sanskari hai hum, ye nahi karte hain. While actually there's no such concept in the current generation of sexual activity being related to sanskar. I mean, there's no such connect in this generation. It's just one activity. So
I think in your talk, Dr. Archana, you mentioned one word very consistently, and it is not being judgmental.
G. It's very tough, sir.
That probably
As a
explains what you're saying.
बहुत मुश्किल होता है, sir. We learned that from अपने बच्चों के साथ भी. I mean, you don't like it, but you say, okay, if that's what you like. I mean, because it's changed. The generation has changed. The value system has changed. We have to accept them.
Yeah, actually, if I can share my experience, ma'am, what has really worked in our journey of advocacy, many a times, like you said, that we have to go to their level to create safe, vulnerable spaces. I think today's takeaway, in my opinion, is this is the key for, what we are discussing all over the globe. Language matters to be able to reach their, faith and comfort level. From the clinician's perspective, also language really matters, like creating these safe, vulnerable, non-judgmental spaces. And also from a peer support group, quite often people reach out on social media because they think you won't judge them. It's because when you are ready to be vulnerable yourself. So this is what we are also observing in our advocacy journey. And when we are able to relate and tell them that, oh, when I have fluctuations of BG levels, then if I'm constantly going through hyper and hypo, I become irritable, I behave cranky, then they feel they can share with you. So the key to getting people on board to speak up is just, I think, creating these safe, vulnerable spaces.
I think somehow we have to remove the barrier. I think for this, what I understand is the last part of Dr. Archana's talk should come first, and that is psychological issues. And psychology is nothing, I mean, I try to understand it very deeply and through my own way, and then what I realize, my understanding matches with all psychiatrists and the psychologists. So basic thing in psychology is what? At least let person come out, let him or her say, यार आज गर्लफ्रेंड ने मेरे को रिजेक्ट कर दिया, उसने कह दिया तेरे को डायबिटीज है तो उससे कुछ हो नहीं पाएगा। अब सर मैं बताओ मैं क्या करूं, मैं क्या किसी लायक नहीं हूं? And then one dimension merges into other dimensions. I mean, he's psychologically disturbed. He faces problem in adherence. He faces problem in professionalism. He faces problem in the relationships with family relationships. So many, everything is interlinked. So very old saying is that everything is interlinked. So let the people open up. When we are able to let people talk, उसको तुम 2 मिनट दे दो, आप बात तो कर लो, बात करने से ही आधा निकल जाएगा. I mean, this is the way I perceive.
That
And
is true, sir. That's very true. But often when it's not possible, I would just like to also emphasize the importance of structured screening. So more and more that value is coming up, and maybe it should become part, maybe I would strongly recommend it become part of our protocol. There is always a chance of over-diagnosis, and hence it has to be done very well with validated scales, language, counseling, but it also can really, really pick up cases which otherwise would not open up.
I
And
agree,
even
because
if you have a false high, it's okay. One would take care, and some of them would not be needing that care.
I'm sharing Indian data, Dr. Archana, and it was published 2020 or so, and more than 60% with type 1. Some psychiatry journal, Indian journal, have some sort of psychological or psychiatric issues. So it's so big, and once people open it, I think many things would be resolved.
We have
Yes.
one more question. Like when a type 1 is open to marry another type 1, should we discuss with them about the probability of their child having type 1 or not? So any of you doctors can take that question.
I think if two are marrying together, chances of developing diabetes is little more. I mean, if we compare to type 2, if one type 2 is marrying to another type 2, chances are 50%. If two type 2 are marrying, chances are more than 80-90%. Type 1, 3-4%, one parent, and both 7-8%, something like that. So it's not very high. So it is a good idea to marry two together. And second thing is social acceptability is also quite a lot. The understanding is also quite a lot. But I think I had a paper in RSSDI, and it was where when I showed that the girls are ready to marry type 1 boys, but boys are not ready to marry type 1 girls. So this is another contradiction that we observed. I think it was 10 years back or so.
And I agree that it has to be told, because even if the decision is not to marry or not to have kids or whatever, but it's a conscious decision. There cannot be any decision today made in a false belief, right? So it has to be absolutely told. Of course, there's also a way of telling it, the narrative, right? So you have numbers, you have percentages, then you also have the fact that they are not the offspring of parents who had type 1 diabetes, right? Most of them would not be. And then if they still got it, so it's a chance. So things like that, all those things have to come in.
I think again, I'll share my experience. Most of my type 1 marriages with children, none of them as yet have type 1 diabetes. None of them. I think Dr. Manisha has worked very closely with me. We have a number of presentations. I don't think there's any. And many of adults got married and they have children.
So far, to best of my knowledge, we do not have any like couples who type 1 having they got married, but probably in our UP region it is like that. Whereas I spoke with Mehak one time and she shared her data. When they in Delhi, the prevalence is more. Right, Mehak? Like, yeah, as you said, like there were the more people who were Delhi based or that region, there when the couple who both are type 1, the child like their outcomes, like the child or even have a type 1 diabetes, they suffered more.
We
So
have type 1s where both parents are type 1, where a single parent is type 1 and the child has type 1. I think Archana ma'am also have some in their clinic where the parent
Yes.
and have
I
type
have
1.
quite a few. I have quite a few, but not both parents being type 1. We have parent offspring, we have multiple siblings, first degree relative, second degree parent child.
Yes,
Quite a few.
same. Also seen multiple
But
first,
not
second.
specifically father and mother both being type 1 and the offspring being. So that is not what we have seen, but we have not had that many marriages also.
So we have one more question for Archana ma'am. So we spoke about the importance of mental health as well as, you know, how we are observing the psychosocial impact of living with type 1. So in a case where we don't have a trained counselor available, in such cases, what would be your recommendation? Like, how do we handle such situations or cases where they need more counseling support?
So I think Udan is a right example, because in our area, we did not have counselors. And of course, there's a lot of social barrier in wanting to go to a counselor. I mean, coming for insulin and coming for strips is one thing, and come for HbA1c test and taking time out from your work to go to a counselor, sometimes not accepted. Even when we tell the parents, they sometimes will not believe it. And they say, you're making too much fuss about something which isn't. इनको टेंशन लेने के लिए क्या हुआ, खाने को है, छत है, school है, friends है, और क्या चाहिए, you know? So they're not willing to accept that. In such cases, I would suggest there are some newer options today, and that is technology comes to the assistance, and there are some very good support systems online. There are some very good apps which are meant to handhold you through your distress times. And these are very well validated. There are also online counselors. These are very well privacy maintained, globally approved. And recently we have started a pilot in Udan where all our young people, because they're living in rural areas, parents are not willing to bring them to counselors. And we realized they had very high risk scores when we did their depression and distress anxiety scales. So we are doing a pilot with a group called WISA, which is one of the global mental health support systems, which is, so like that, there are many such communities which can help. So we must reach out, we should not let it go. That is important. Another point is we can also train our own team. Of course, all studies have shown that it doesn't work as well as a professional counselor, because we understand the right reasons. But at least there is something called as mental health first aid. So entire team can learn mental health first aid, so that the first point of contact, at least the language is right, the problems are picked up, some hand-holding happens. So this is very important.
Also, in your experience, whenever we try to co-opt caregivers or parents into, educating them about the condition, or let's say discussing these mental health issues, how often are they receptive and cooperative? Because normally we all assume, like when you were discussing this aspect, the one assumption that we all live with is family support is always taken for granted. Like, for someone like me, I would think, oh, family should understand. But this opened up a plethora of thoughts in my mind to say, what is it different, and how has your experience been?
We have our major challenge is parents, caregivers. If you give me kids and I wait for them to become 13, 14, and I feel I can, channelize them with all the tools that we have, because you have a blank slate somehow. But in parents, you have to unwrite and rewrite, and there's so many preconceived notions around mental health. So, I mean, I think it's even a bigger challenge for them. And to be very honest, they don't know what to do with it. They really don't know how to handle it. If they have to work, they have to earn money, they have to take care of other kids, home, on diabetes, on top of that mental health, it just becomes too much for them. So they just are in state of denial, or I'm not able to accept. So we often have to bypass them, but which is not possible in people below 18. So it's a challenge, yes.
And I think the transition also, Dr. Rishi sir, how do you feel that the transition is when they are moving from this adolescence to the young adult? Like, when do they themselves feel empowered to speak about mental health, or their real issues which are related to type 1 or other autoimmune conditions? Because until the age of 15 or 16, they're always accompanied by caregivers, even if they are going for a consultation. So what is like the challenge that we face when we have to address these issues, co-opting with the caregivers, especially at this transition time from adolescence to young adult?
Actually, there are two things. Many things are interlinked to what you're talking. One is the core medical part.
Yeah.
Core medical part, what is happening? Diabetes is it is seen by diversified specialists. So, like I remember, I'll quote Dr. Manisha. Whenever she looks at type 1, she looks at pubertal status. What is testicular volume? What is breast size? B1, B2, B3, pubertal. So at least when we are aware that puberty is progressing, at least it is in clinician's mind. Was looking superficially, I mean, you can't say, you can simply have a little bit feel of breast, otherwise what is happening to actually people will not come to know. So when a clinician has this thing into their minds, which is most often not done. So when this is not in mind, then you can't think, acha 14 ka ho gaya, then let us talk about it. No, it's not the way. When it is progressing, the event is progressing, when physical event is progressing, then you should put a word. That your blood sugar may be little bit this way or that way. You might be little erratic also, which is correct also, and which is wrong also. If you feel it is too much wrong, you can first talk to your parent, then we can talk to us or something. Then let this go into the brain of child first, or the adolescent, or the child, adolescent, and the adult. So this is one thing. And one good thing with us is that majority of our patients are seen, even those who are core pediatric endocrinologists, they are not transferring their patients to adult endocrinologists. Even if so good part is all of these patients are going to stick to one doctor until unless they feel like changing. जब मनीषा को हमारे पेशेंट ज्यादा पसंद आ जाते हैं तो मनीषा हमको देखने, जब मनीषा के मेरे तो हम लोग देखते रहते हैं. So it's like that. अर्चना के देखने लगते हैं. So it's like that. So something like this. But at least one person is willing to serve for long and for life. So this is the good part in transition. But
Sir,
again,
you're very right, sir. The whole
huh?
protocol, the part you said about being sensitive, being aware, I mean, whether you're an adult physician, endocrinologist, or a pediatrician seeing, because in our country, we cannot have everyone being seen by the specialist.
Actually, problem with us is also we are too much overworked also, and we should not copy West. We should do in our own way.
But we should not miss. As you said, all these things should be, like as you said, that Manisha is
should be
looking at.
mind, and we should actually miss less. To be honest, we should miss less.
Right. So
Because
checklist to
I mean, the way we talk in forum and the way it should be done, there is a difference. And if suppose the way my Western friends sees type 1 or type 2 diabetes, तो हमारी क्लिनिक के तो शीशे फूट जाएंगे, सर के एक को बाल ही नहीं बचेंगे. I mean, they see 10 patients per day, 5 patients. Manisha was there, and how many patients were seeing there?
In US, they usually see like they give per patient half an hour. So maximum they'll see 8 patients, 8 to 10. And then at the end they'll say today was a very tiring day.
And when they
I was with Dr. Jamie Wood and she used to saying this.
Cleveland Clinic, she was there. So we have to devise our own way of doing things, and we have to serve people.
Very
So
true.
that is,
Also,
I
sir,
think,
we have to be culturally sensitive. What works in, each culture, right? That also.
because there they talk more about CGM data, they talk about pumps, they talk about carb counting. Here, I mean, what I feel, if we talk about basic things of carb counting, dose titration and monitoring is actually very important. Amit, I'll tell you a very small story which I usually say to my patients, that usually what we do in real life, we befool बच्चों आप लोग भी सुनो, हम लोग लाइफ में usually लोगों को बुद्धू बनाते हैं ना, we befool others. Am I right? But what happens with diabetes?
We fool ourselves.
Yes, and why and how? If you monitor yourself and you start doing monitoring, and then after a while, maybe 3 months or 6 months, you realize my sugars are stable, then you reduce the frequency, and then you further reduce the frequency. And then there comes a point, I'm all right, I should measure it if there is any problem. So you measure it maybe 1 value per week, 2 value per week, maybe once in a 15 days, all good people. And a very strong psychology is there, because what our brain says is always correct. This is psychology with which we have been living. So here we have to contradict our brain, our thought process. This is where we are being befooled by our own brain. And if we are able to combat even this simple thing, that if you measure every day your blood sugar 3 times at least, your control will remain always good.
That's probably, sir, where the role of all this peer group interaction,
Yes.
so that remotivation, reinforcement,
whatever
everything
you
comes
do,
in.
whatever you do. I mean, even US 50%. So it's a very challenging thing. Very challenging. I mean, we are talking about good things. Keep talking, keep doing. But at least 3 values per day. Measure for a year, then for next 3 years, and then forever. So, this is a problem.
I think there's another difference between the way it is practiced in the West and how we go about here. Is in the West, it is always there's a concept of value-based services, and I think that is still not there in India. Maybe it will come. So for those who does not understand what value-based services is, it basically means that if I can create a value out of my service by giving better care and leading the patient to a better outcome, then as a professional, I get rewarded with a higher percentage of the fee by the insurance company. So this is what value-based service means. So that's from also one angle, as a professional, whether you are a peer group advocate or whether you are a doctor or a clinician, value-based service is also an encouraging, way of giving your best with the patient. So seeing 10 patients, 12 patients in a day and giving your 100% with the patient at every minute actually really works out. But for our equations are completely different. But having said that, sir and ma'am, I've always seen that as clinicians, Indians, we are the most adaptive community. And we are always willing to adapt, we are always willing to learn. And so a more of a collaborative thing. That's where, a clinician, a peer group collaboration. And even today we see that still a large section of T1Ds are treated by physicians. And I think Archana ma'am we were discussing this the other day when we met at Varanasi, that there still is so much of a physician-driven, approach. And just because of the lack of the right collaboration, it's not about being a specialist or not. It's about the lack of right collaboration. We are not able to deliver the best of the support. So yes, we are different in the way we approach. We see a lot of larger number of patient in a very small span of time. I think Dr. Manisha has told me the patient load at Dr. Shukla sir's clinic and hospital. So yes, the thing is different over here, but at the same time, it's very important that we all understand that the 10-minute or 15-minute that we are giving to that patient, we must give our best, because the patient comes to us expecting that we give our best to each and every patient, whether it's patient number 1 or whether it's patient number 100.
We have a very
And
strong support system also. I think two counselors, separate pump educators. So there are a number of people who are there to help. Actually, what you're talking about, Amit, about the things, I respect it, but we are moving to exactly the opposite direction to what you are saying. Archana is helping so many people. I am also helping many people. And what happens when you help them? Then there is entity known as dependency.
yes,
And then what people will do, I mean, I don't know what is with Archana. Many of my patients, they skip their 2 days insulin because insulin was not available. And then develop ketoacidosis. They find it worth spending 40, 50,000 to treat ketoacidosis, then purchasing insulins. So there is entity known as dependency. And other thing is taken for granted approach from the clinicians. Taken for granted. I mean, we are helping, तो क्यों नहीं करोगे? नहीं करते जाओ. I mean, people come to this tune. I don't know what is your experience. अपनी खुशी के लिए तो करते हो. अब भाई अब चलो ठीक है.
true.
I'm sharing my pains also.
So does वो भी sir narrative है जो हमें शुरू से inculcate करना होगा. What we also learned it the hard way.
But I
agree
think,
with you.
but I think I'm sharing my thought process that I shared with Dr. Manisha also, because what happens to a sunshine? Sunshine remains same to everyone, good or bad. So let us keep joining hands together. Let us keep working. And very highly appreciating Amit for your work. It was a very, very busy day for me. I mean, 9:30 till now, I'm continuously on. And but end of the day, I will have a very comfortable sleep. So you made my day very good. Actually, I'll share my day. I mean, 2 मिनट और लेंगे बड़ा मजा आएगा. एक आदमी आया दिखाने, वो he gave me a garland and a patta. Manisha को मैंने बुलाया, and then 2 sadhu baba came. He touched my feet. Suno. I mean, this was the way we moved. And then there came a guy. Different. Manisha, you are not witnessing all this. का सर मैंने आज तक मैंने ना अपनी बाप की बात मानी है, ना बहन की मानी है, और केवल अब 2 साल से आपकी बात मान रहे हैं. पता नहीं क्यों मान रहे हैं. हमने कहा तुमने यार लड़के हमसे जीत लिया. So this is the ending with you, Amit. So end of a great day with you and a very soothing day. I'll have a more peaceful sleep tonight. And God bless you. Keep doing good things. We are always at whatever stand, but even if I am not there, I'm sure you'll take these things to a long way and into a beautiful way. Keep doing. All young people are there. Manisha is there. Dr. Archana is there. Riddhi is there. All Mahak is there. So I'm happy to see all of you. Keep growing, keep doing, keep helping. And never be judgmental. Archana's word.
That's so important.
कि इसने मेरे साथ ऐसा किया था, ये तो ऐसा ही है, don't do. Keep doing. I mean, if nature has given us opportunity to shine like a sun, then let us not have a differential behavior. And this is the way life goes. Thank you
I think
so much.
today's session was actually an empowering session. I think when we started the concept of having a collaborative group, I think it was meant to see a day like this where we have a clinician, peer support, group members, advocates intersect, discuss, their life experiences and bring those common topics on the table that can actually be dealt together for the best interest of the patient. And I think that's what we are going, right? We are going into a more patient-centric care, where nothing is more important than the patient in the center. And we are really, really happy to have mentors like Dr. Rishi Shukla sir, Archana Sarda ma'am, and to all of our T1D advocates who've been working so wonderfully, collaboratively together. Mahek has been leading this right from the time we started this, and she has rolled in so many of our advocates to join us, sharing this common goal. Ritti has been fantastic, and I'm so happy to share that we have so many new members joining us every day. Even we have some members joining us from across the globe who wants to be part of this common goal, that the whole idea is to take this together, because type 1 disease is one disease that cannot be treated without connecting, with the patient. The physician or the clinician needs to connect, and the patient needs to connect with the clinician. That is so very important. So thank you very much. Thank you, sir. Thank you, ma'am. Riddhi, over to you. If there is
Thank
further
you.
questions or whatever, what to do.
I think we'll, just look at the time. I think we've covered the
Yeah.
questions. All I want to say on behalf of all the T1s attending this session, if I can take the liberty to say that, yes, we know we are very difficult to handle because it's not a one-person job.
Yeah.
So I think we put a lot of expectation out of one clinician or physician. This is my takeaway for today. Like what we expect in new age clinicians is that the person should be medically advising us, also be a counselor, also be a mental health expert. It's not fair. So we realize that it takes a team, it takes a forest to handle people living with type 1, and which is where we all commit our lived experiences so that we can together collaborate and improve the lives of other T1s, especially those coming from areas where they need more support. So let's pledge together for better care, but we are mindful that you cannot do it alone. We can't expect you to
We
bear
need you.
this burden. And we
Certainly,
need you all the
guidance
more.
at every
So-
step. Whatever we do, we need guidance like mentors like you. So
Absolutely.
be there and bless us always and guide us.
Thank you so much.
We
Thank
are
you.
Thank you
definitely
very
Wonderful
much,
session. Thank
Rishi
you, everyone.
Archana ma'am. And one last thing is that it's Mental Health Awareness Month, the month
Yes.
of May. So very rightly, Dr. Amit has chosen this, theme, and the right set of speakers have come in today for us. We really feel so lighter and empowered. So thank you, Team Empower, as well as our leading doctors who have given us this wonderful, engaging talk.
Thank
Thank
you.
you. Thank you.
Good night.
Good
Have a
night,
good
everyone.
one.
Bye.
Good night.
Very,
Bye.
very
Bye.
nicely conducted show by Riddhi. Thank you, Riddhi. Well done.
Thank you, Riddhi. Thank you for the
Thank you,
fantastic
everyone.
Bye-bye.
Bye.
Thank
Night.
you. Bye bye. Good night.